can tell us? It's amazing. This little investigation of 3 inch by 1 inch can give you very much information. It is, I call it like my textbook of hematology. It is like hematology, Williams hematology, because everything is there in that peripheral smear. So I look at it as an organ. Blood should be seen as an organ and not like a floating different cells, because these cells you must find and see the type of the cells. What is their number? Are they relatives? You must see what is their relationship to each other. Are there any abnormal cells? And of course, the plasma, which will affect all these cells. So you people must understand and look at the peripheral smear as an organ, and don't look at it as a separate fluid which is precipitating or flowing all over the body. Wait. Okay. Peripheral blood smear, besides giving you all the information, we are using hematology analyzers. This will confirm your blood counts, which is very, very important, because all counts should be confirmed by your peripheral smear examination, and you must recognize what is the variation from the normal. In doing that, you must recognize the pattern. What is the pattern of these cells that they're trying to show you, and use your information about those cells, their relationships and their number. These correlate clinically. It is absolutely necessary. Hematology cannot be done without clinical correlation, because right from age, sex, and the clinical few findings, you cannot come to the diagnosis of any hematological problem. So it is like a detective's work. I always call it that. And this smear gives us a direction. Always tells you which way to proceed, because in every patient, you can't do all the cells, all the tests that are necessary in an individual in hematology. So the direction is given by the peripheral smear. All of us are very familiar with a good peripheral smear. It shows you nicely stained RBCs with the central pallor, a little bit of overlapping, and of course, well-stained WBCs. One big rider, a fresh smear or an anticoagulated smear. It makes a lot of difference when you are interpreting the peripheral smear, because the longer it stays in EDTA, there are a number of changes which take place. And if you make a smear from that blood, you are going to see artifacts. Like in this one, you can see a neutrophil, which is almost looking like a karyoretic neutrophil. Here, it's a mononuclear cell. We don't know whether it's a monocyte or a lymphocyte that is showing petalling, and you cannot interpret anything on this. Coming to the RBCs also, there are many, many changes. And some of them, like shown here, is pycnocytes or acanthocytes, whatever you may like to call it. So please, when you're examining a smear, it should be made within an hour of collection of the blood in EDTA. Ideally, I insist on a fresh finger prick or the first drop from the needle if there is a needle syringe collection. These days, we are collecting in vaticaners, and in that case, it becomes difficult to take a fresh first drop from the needles. But I would request all of you to pay attention to the making of a smear and within a stipulated time. When we are talking of a peripheral smear examination, we are mainly talking about these three cells, the red cells, the white cells, and the platelets. And the red cells basically for all types of problems, especially anemias, white cells for infections and PUO, and platelets whenever the patient is bleeding. Coming to the red blood cells first. Now, this is my first case, which I have given few people. This is an 18-year-old boy. Actually, he walked into my clinic and he looked 7-year-old. He was so short-statured, but he looked like a small 7-year-old gentleman with a pant and a belt and a shirt. I was amazed to see. I thought 7-year-old boy. But when he said he's 18-year-old and the mother was with him, I was a little surprised. He had delayed puberty, obviously, very low in weight and height. Repeated transfusions in the past, but the first one was given at the age of 5 years. Received multiple courses of supplements and iron. Clinically, only pallor. There was no icterus, no hepatosplenomegaly. So I gave you the findings of his CBC. It showed. Can somebody describe some of the findings in this, please?
Ma'am, hemoglobin is 6.2 gram %,
Yes.
which is lower than the normal limit. RBC is 3.6 million per cubic mm, which is also slightly lower as the normal range is 4.5 to 5.5.
Okay.
NCV is 60 femtoliter, which is again low as the normal value is 80 to 100 femtoliter. And MCH is again very low, 17 picogram. The normal value around 27 to 32 picogram.
Right.
And WBC is 48,000 per cubic mm, which is we can say in the lower range, lower normal limit.
Okay.
And neutrophil is 33% and lymphocyte is 54%.
Yes.
And retic is 2%, which is in the normal range. Normal range is 0.5 to 2.5%.
Yes.
And platelet count is 4.6 lakh, which is again on the higher normal side.
Very good, Charu. Yes.
And ferritin level is 1.7 nanogram %, which is low.
Which is low. So he was investigated for iron deficiency. Basically, if you see this histogram, it tells you it has shifted to the left. That means more towards the microcytosis end. So we were looking for all reasons for iron deficiency in this patient. Did the stool examination repeatedly for occult blood, which came repeatedly negative. He had some giardia, but that was it. That was the blood picture of this boy. Can you describe somebody the blood picture of this patient? It confirms the finding of microcytosis, hypochromia, MCH low, little anisocytosis, and little polychromasia. Few target cells here and here. Otherwise, it's essentially a microcytic hypochromic anemia. Now, My first question is, what is your interpretation of the CBC values, which we have just done? We are thinking of a microcytic hypochromic anemia. So what are the differential diagnosis that you people think? Anemia, we know, is depends on who is your patient. A reduction below normal for that age and sex. It's absolutely necessary that you know who is your patient, at what age, and what is the sex of the patient before you can say that their patient is anemic or normal in hemoglobin. We know WHO has certain guidelines, and they have said men over 15 should be above 13 grams %. They have given the other ranges for different age groups. Surprisingly, WHO that time did not give any neonatal ranges, which DESI has given now. However, our patient we know is an 18-year-old boy. Now, this 18-year-old boy is short stature, which tells us that the patient has had a chronic anemia. There is a growth defect. He has not grown. At the age of 5 years, he had his first blood transfusion. Repeated supplements of iron have been given, but he has not responded. He's still at 6 grams. Now, what can be the reason for this? We know that RDW is an important factor when you're interpreting your CBC value, correlate with your PBS value. And if microcytosis with high RDW, of course, it again confirms more likely to be iron deficiency anemia more than the thalassemia. So what further investigations would we like to do? Can somebody tell? What would you like to do? Now you have a patient who is chronically iron deficient, not responding to therapy, no organomegaly, no jaundice, and has confirmed iron deficiency. What further investigations would you like to do?
Electrophoresis to rule out
Yes.
Serum ferritin.
Yes.
any malabsorption because of giardia has come positive.
Yes. So we are thinking of microcytic hypochromic anemia. We know it can be of two types. It is either due to iron deficiency, in which case either it is nutritional, very, very common in India, or iron absorption, like in celiac disease, increased iron requirement in pregnancy and growing child, inability to transport iron, which is transferrin deficiency, chronic iron deficiency due to chronic hemorrhage, focal sequestration in the lungs and kidney, we know can be there in many cases of, you have telangiectasia, which bleeds in the intestines, and you can have Goodpasture syndrome, which can bleed into the lungs, and these are all due to pure iron deficiency. Next is those with the normal iron stores. The normal iron stores are usually due to chronic disorders like COX or CRF or rheumatoid arthritis or collagen disorder. Thaltrates come into this category. Unstable hemoglobinopathies, sideroblastic anemias, lead and aluminum poisoning, and hyperthyroidism all come in this category with normal iron stores, but microcytosis. So can peripheral smear help in differentiating between iron deficiency type of microcytosis from the iron normal iron status? Yes. If you look at this, Jasmita mentioned yesterday, on day before yesterday, anisochromia. Anisochromia is one finding which helps you to show that there are some cells which are fully hemoglobinized, but there are many hypochromic cells, and this is called anisochromia, very typical feature of iron deficiency anemia. Whereas in patients of thaltrates and anemia of chronic disorders, normally you have all microcytes. That means the RDW is usually normal, and the hypochromia is also very uniform in all the microcytic cells. So in this child, we see that there is high RDW, microcytosis, iron deficiency, thrombocytosis mild. The platelets, like she mentioned, is little on the higher side and has mild neutrophil leukocytosis. Neutropenia. He was giardia, stool positive. We were looking for the occult blood. His GI survey was also done. So what further investigations did we do? Yes.
Serum TTG level can be done.
Serum
TTG level to rule out the celiac disease.
Very good. Yes, serum TTG can be done. Serum TTG, normally we prefer IgA of serum TTG. So this particular case, retic count, iron studies, ferritin, electrophoresis, fetal hemoglobin, A2 estimation, all these are the tests which you will recommend for a case of microcytic hypochromic anemia. Retic was 1% in this boy, 8 transferrin saturation, ferritin we said 2, normal 8 in electrophoresis, and fetal hemoglobin 0.5 with A2 0.1. This was classical iron deficiency. What did we do further? Upper GI survey, which was otherwise normal. We treated giardia. Oral iron was given but not responding because this boy turned out to be, very rightly said, serum TTG test IgA positive with a biopsy, and he turned out to be celiac disease, which will respond only to parenteral iron. The important thing is that we have to ask for the serum TTG test. Don't forget to do that. Celiac disease is not very uncommon in India, and we have to make our clinicians very conscious of this thing, that there are missing some cases. Now imagine if somebody at age of 4 or 5 years had realized that this boy was not responding to oral irons and hematinics, and if he was given IV iron, this boy would have been a handsome, strapping 18-year-old tall boy. But nobody bothered. He was also going shopping from one physician, pediatrician to another, repeated blood transfusions being given, oral iron supplements being given. So what I want to impress upon all of us and our younger lots, that please ask for serum TTG test also in a patient of iron deficiency anemia. We have 2 boys here. Of course, thaltrate, if hemoglobin may be the same, the RBC is the one which is low in iron deficiency. We know there is little erythrocytosis in a thalassemia trait. Both have microcytic, but thals are more microcytic than the pure iron deficiency. And of course, the RDW is just above the normal in cases of thaltrate, or maybe even normal. However, in iron deficiency, the RDW is very, very high. So patients whom you're suspecting that are heterozygous, you will do this test, and A2 estimation is the one which will confirm that the person has normal iron status, transferrin saturation normal, ferritin normal, and has A2 of 5.5, confirming the diagnosis of beta thal heterozygous. Basophilic stippling, I put a lot of significance to this, but there is a rider. Basophilic stippling, if you make from an anticoagulated blood, may not be very clearly visible. You will miss it. In a fresh smear, they are beautifully seen, and we know that if it is microcytosis with basophilic stippling, you will think of thalassemia trait. Pure iron deficiency rarely may show you, but normally it does not show you basophilic stippling. If you are seeing normocytic red cells in the peripheral smear with basophilic stippling, you will think of some kind of a dyserythropoiesis, like lead poisoning can be there, or maybe sideroblastic anemia. It's a macrocytic blood picture. All your peripheral smears are showing you macrocytosis. With basophilic stippling, please think of megaloblastic anemia. But basophilic stippling is something which you make in the laboratory. And for that, you have to use a fresh blood smear. The moment it touches an EDTA, you will miss the basophilic stippling. So that is the flow chart that we follow. Here again, you see that it is microcytosis. This microcytosis tells you from the peripheral smear, gives you the direction to do the serum iron TIBC. If the iron is high, bone marrow iron, and it may be sideroblastic anemia that you're looking at. However, with a normal or high, with the hemoglobin synthesis, you will do the hemoglobinopathies, rule out, and you will do the A2 estimation to rule out beta thalassemias. And if it is low, obviously you will ask for ferritin, which is usually normal or high in these two cases. This ferritin is low, which confirms iron deficiency. If ferritin is normal or high, you will look for anemia of chronic disorder. So that is the flow chart. And the blood film TDS helps you in deciding which way to proceed for investigating a patient of microcytosis. Coming to the next case. It's an 11-year-old female, easy fatigability, pallor increasing, jaundice for 1 month. She has mild hepatosplenomegaly. That's the CBC and the blood pressure. I will show you. Can somebody read this hemogram findings for me, please?
HB is 3.1 gram percentage, which is very much low.
Yes.
Then PCV is 9.5. That's the normal range is about 0.45 plus or minus 0.05, so that is slightly increased. Then MCV is 106, that is also increased.
Yes.
MCH is 34.8, it is also slightly increased, but MCHC 32.6 is a normal range. Then RDW 30% is like very much increased. And reticulocytes count 4.5% is also very much increased because 2.5 is the higher limit.
Yes.
Then platelet is 1.2 lakhs, slightly lesser than the normal range. Total bilirubin is 3.2, slightly higher than the normal range, which is 2. Conjugated 0.6 is normal, unconjugated it is 2.6, and it is high compared to the normal values.
Yes, and the WBCs are low.
Yeah, WBC is low.
Yeah, so this is a patient of what will you call this? Three triangle?
Pancytopenia.
A pancytopenia with a raised MCV definitely tells you that with an RDW high, that you're looking at macrocytic anemia. Look at the histogram. If you appreciate the histogram, which is telling you, showing you that the RDW is very high, look at the base of this. It is widespread. But please remember, the MCV that you see here is an average of this as well as this. The counter cannot give you, it will only give you the average of the readings of all the red cells. So 106 does not mean that all the cells are 106. It means there is RDW is high. So you have all types of cells, some small, some very large, but mainly the right shift to the left, right shift of the histogram of the RBC. You have little jaundice clinically also. This girl was seen to be having jaundice, and it's indirect type of jaundice. So any comments on that? Yes?
Associated with hemolysis.
Hemolysis, yes. So maybe this child is having some kind of a hemolysis, which is increasing the unconjugated bilirubin. This is the blood picture of this child. Can somebody describe this blood picture for me, please? Peripheral smear?
Ma'am, peripheral smear is showing hypersegmented neutrophils, pro-ovelocytes, and teardrop cells.
Yes. And look at the anisopoikilocytosis. Look at this and look at this. That is what is causing the RDW to be so high. So this is, yes, right? This is hypersegmented neutrophil with fully hemoglobinized macrocytes. This one is a little macro-ovalo, teardropping, fragmentation. And this is a typical picture of high RDW with macrocytosis. So what will you think of? How would you approach a case of macrocytosis? Can somebody approach this case for me?
We see the retic count.
Yes.
Ma'am, if it is in the high range, we see for a blood loss.
Yeah.
Ma'am, we can obtain B12 level.
Yes.
And ma'am, folate levels also.
Folate levels also.
We can do workup for some hemolytic anemia also because retic count is high.
Yes. And indirect hyperbilirubin.
Yes, ma'am. Unconjugated bilirubin is also high.
Unconjugated bilirubin is there. Okay. So what further tests would you like to do? First, we must see macrocytosis on the peripheral smear can be due to many reasons. B12 folate, of course, are the common reasons in our country, which can be due to malabsorptions or any other intestinal problems. Liver disease, alcoholism are the other causes of macrocytosis. Besides aplastic anemia, hypothyroidism. In pregnancy, a little bit of macrocytosis does occur because of relative folate deficiency, or sometimes they are deficient in B12 as well. Cases of MDS and post-chemotherapy, also they are macrocytic in this. Can a peripheral smear help us in differentiating between these types of macrocytosis? Yes. If you see the B12 folate, the megaloblastic PDS, hypersegmented neutrophil, with this much of macrovalocytes and RDW is a typical picture of macrocytic megaloblastic anemia. Whereas the anemia of liver disorders, if you see here, the poikilocytosis and anisocytosis, that means the RDW may be very little high, not as high as in this particular case, because these cells are macrocytic, but they are fully hemoglobinized, they're not hypochromic, they're target cells. One thing about these target cells is that they are fully hemoglobinized target cells. They are not hypochromic target cells, which we see in thalassemia traits and in some cases of iron deficiency anemia. So target cells in a normochromic cell with macrocytosis, you can see acanthocytosis on the edges. This is a typical picture of chronic liver disorders, which can cause macrocytosis with folate deficiency. Here, you can see hypersegmentation or macropolycytes are a feature of folate deficiency. Now, this is how you will, from the peripheral smear, differentiate different types of macrocytic anemia and proceed in that direction to investigate that particular case. As I said, you can see in pure B12 folate deficiency, besides tear dropping, you can see Cabot's rings, which are seen in these polychromatophilic macrocytes. In liver disease hypothyroidism, these target cells are fully hemoglobinized with hypersegmentation. So, how will we approach this case now of macrocytosis? This is clinical examination, but my main thing is I first ask for serum LDH. Besides all the other causes to be ruled out for macrocytosis. That's my algorithm for a case of macrocytic anemia on the peripheral smear. And you have a retic count, which comes next with the LDH. These are the two important tests, first line, which you will ask for any patient of macrocytic anemia. If it is high, you're probably looking at acute blood loss or hemolytic anemia, like we can think of this case also. However, if it is normal or low, and you have a LDH which is normal, you are looking at non-megaloblastic macrocytic anemia. This non-megaloblastic macrocytic anemia can be alcoholism, liver disorder, hypothyroidism, or it can be dyserythropoietic myelodysplastic aplastic anemia, in which case you will need to do a bone marrow to confirm the diagnosis. On the other hand, if the LDH is high I mean above 1000 international units, I would straight away either ask for B12 folate levels and confirm either deficiency, or normally what I do is I see macrocytosis, I ask for LDH. If the LDH is more than 1000, 2000, 1500, I straight away tell them to try B12 folate therapy for 10 days, do the HB and retic count on the 10th day. And if the reticulocytosis response, what do I mean by reticulocytosis response? The retic count going about 20%, 18 to 20%. Then I'm happy. The response is good. Probably mainly megaloblastic anemia. I don't even do a bone marrow in these cases. But in case the LDH is high, but no response of reticulocytosis on the 10th day, then bone marrow becomes mandatory and you have to do a bone marrow to rule out these other dyserythropoietic or other causes of MDS, which may be there. In these cases, normally the LDH is borderline high, 500 to 800 range. Usually doesn't cross 1000, but depending on what's the level, you can then ask for a bone marrow and then proceed to investigate a case separately. My one question is, everybody, why this bilirubin in this particular case? She was a case of pure B12 deficiency, malabsorption with pancytopenia, macrocytic anemia, and B12 folate deficiency. Why the indirect hyperbilirubinemia? Can somebody explain this?
Ma'am, there is ineffective erythropoiesis is there. That's
Yes.
why cells are lysed. That's why unconjugated bilirubin is high.
Lysed, okay. So there is hemolysis,
Hemolysis.
right? Where?
Extramedullary. Like there is-
This is usually medulla, intramedullary. This happens in the bone marrow. The cells do not have B12 and folate. They cannot mature further because their nucleus is not maturing. Because the nucleus is not maturing, it cannot incorporate iron in the cytoplasm, and they are just multiplying there, and they die there, which is called intramedullary hemolysis. Very typical feature of folate B12 deficiency.
Ma'am?
Yes.
Ma'am, would you like to invite comments from the chairpersons?
Yes, please. I'll be very happy, Mr. Basu.
Yeah,
Yes.
nice cases, ma'am. In this particular case, I had a little query as to why the reticulocyte count was raised. Because generally in megaloblastic anemia, there's a bit of reticulocytopenia, usually.
Yes.
Either low or normal. Here you had a retic of 4.5. So had the patient, was the patient receiving some kind of hematinics or B12?
Yes.
Or when you have a high retic, I would also like to, as one of the students did say, could it be an underlying hemolytic anemia which is being masked by folate deficiency?
Definitely.
So that's
Very
one
true,
little
Dr.
query I have. So why was the
Yeah,
retic?
I'm glad you brought out this point, because this patient did receive iron and folic acid as a combination, was not treated with B12. But yes, you can think of a chronic hemolytic anemia. These chronic hemolytic anemia patients do become macrocytic and megaloblastic due to the ineffective erythropoiesis, which is happening, trying to compensate for the hemolysis. They become relative B12
Folate deficiency.
deficiency. Yes, more folate deficiency. So yes, that's a point. This hemolysis may be chronic hemolytic anemia, and that's why you would like to investigate them for, besides all the other tests, run an electrophoresis or HPLC in these cases as well.
Usually
Thank you,
they have some features of
Yes.
an inherited hemolytic anemia, like splenomegaly
Yes.
or past history of jaundice would be there. But
Yes.
generally, most of the time when you get a high retic, it's because of some kind of hematinics they've already received.
Mostly they
Because
come with some, yes,
Because now
they
it
come
is
with some
taken.
hematinics. You're right, absolutely. Any other comment or suggestion?
There's one question, ma'am. Would you like to take this question right now?
Sure, why not?
What
Yes.
is ineffective erythropoiesis?
Yes, ineffective erythropoiesis is when the nucleus is trying to multiply and mature, and we have B12 folate deficiency. The bone marrow is expanding to try to multiply and take care of the low hemoglobin, but they cannot mature further. So it is ineffective erythropoiesis. The maturation arrest is there in the bone marrow. Usually at the early or the intermediate stage, they do not mature further and they start dying in the marrow. And this is called ineffective erythropoiesis because of intramedullary hemolysis, which is happening inside the marrow. Dr. Basu, any other thoughts on this?
Oh, it's all right. I mean, Varishta had this issue. Just imagine if you've seen the bone marrow in a megaloblastic anemia, it's florid erythroid hypoplasia. But what you see in the peripheral blood is an RBC count which is barely 1 million or 2 million. So basically, the cells are dying out in the marrow. So though erythropoiesis is going on, it is not effective enough to produce the desired number of RBCs. That's ineffective erythropoiesis. And it is because of this maturation arrest that takes place. You can also get ineffective erythropoiesis in conditions like thalassemia, where there is an intramedullary, wherever there is intramedullary destruction of the cells, you will get ineffective erythropoiesis. All right.
Yes, thank you.
Thank you both of you.
Any other comment, question?
Kashyap would like to add some note on.
I think we can go ahead.
Okay,
Ma'am,
thank you.
ma'am, can they be associated with any autoimmune hemolytic anemia along with the macrocytic anemia?
Any chronic anemia can cause macrocytic anemia or folate deficiency because of the ineffective erythropoiesis. Can be chronic anemia, but the blood picture is very typical of macrocytic megaloblastic anemia. Coming to the third case, this is a 68-year-old man. Yes, pain in abdomen, difficulty in walking, pallor, admitted in neuro ICU in an unconscious state. The hemoglobin, as you see, is 9 grams. Can somebody describe this?
Yeah.
What type of anemia is he having? He's a 68-year-old man.
Yeah. So from the hemoglobin is 9 grams, which is moderately low, and the MCV is 89, which is within the normal limits. The total count is 6,800, again, which is within the normal limits, and the platelets are adequate. So from the MCV and the hemoglobin, it looks like normocytic normochromic anemia.
Yes, thank you, Sainda. Thank you so much, Dr. Das. That's right. So this 68-year-old man actually was known to my technician who works in my clinic, and you'll be surprised. She brought this peripheral smear to me. She said, ma'am, this gentleman is known to me. He is admitted in neuro ICU. He's unconscious, and they can't figure out what is the problem in him. And I just had a peripheral smear. I had nothing else, and this is what I saw on his peripheral smear. So I told this girl, I said, this gentleman has a normocytic normochromic anemia. He's unconscious, pain in abdomen, lying in ICU, and he has this. What do you see here? Can somebody tell me?
Basophilic stippling.
Yes. It is coarse basophilic
Coarse
stippling.
basophilic.
Coarse basophilic stippling. So I told this girl, I said, please get his serum lead levels done. She said, yeah, but that's quite possible because he has a foundry. He's in a factory and he has a foundry. And I said, okay, very good. Then that is the reason for this. But she said, sorry, ma'am, because he never goes to the factory. His children go, the son goes. He sits in the office. He's 68 years old. He is now only sitting in the office. Anyway, his blood lead level was found to be more than 50 times the normal level. And he had normocytic normochromic anemia. With all these reasons being there, this gentleman had diabetes. I said he's taking Ayurvedic medicines. Please, always when you're asking for the history or investigating a case, do not forget this alternative therapies that in India people are taking. This gentleman was on an Ayurvedic anti-diabetic tablets. And he started with having pain in the abdomen, which is very common, or the symptom of lead poisoning. So why I want to show this case is that clinically and from the lab side, we people must think of this alternative therapies that people and patients are taking. They do not inform us. They do not tell us that they're taking Ayurvedic tablets or homeopathic tablets. So it's important you interpret the CBC value and you're looking at the normocytic normochromic anemia. We know that it can be due to marrow failure syndromes, aplastic anemia, or can be secondary chronic inflammation, renal disease, liver disease, acute blood loss, or leukemia. So normocytic normochromic anemia, usually our approach is, can the blood film just the direction, and the reticulocyte tells us which way to proceed. If it is high, then you probably are looking at chronic hemolysis, acute blood loss. If it is normocytic normochromic, acute blood loss. Normal or low, then you have to do a bone marrow, looking for renal disease, liver disease, endocrine disorders, if you can find out the secondary reason, or it may be a primary bone marrow problem, which can be due to a chronic marrow failure syndrome, hypoplastic anemia, aplastic anemia, leukemia, etc. It's very important. Once the film tells you which way to proceed, please get the clinical history and accordingly proceed for investigation of that particular case. Any comments or any questions on this case?
Yeah, maybe students, would you like to tell us about the various causes of basophilic stippling, other conditions than lead poisoning? Madam did describe them in the previous case.
Plastic anemia.
Alcohol.
Liver disease.
Any ensymopathy?
Iodine-5
Yes, that's again something that you must keep in mind. Iodine-5 nucleotide deficiency.
Yes.
Okay, that can cause. And for each of these conditions, the cause for stippling is different. Okay, thalassemia is the alpha chains which precipitate, so on and so forth. Okay, so just keep that in mind. It's a useful finding which we generally tend to miss, and we tend to miss it because most of the time we're using stored EDTA blood for making the smears. So it's one of the conditions which is best appreciated in as fresh blood smear as possible. So keep that in mind. And some stains like light stain and all, we get a better than Leishman. So it's an important finding. So
Thank you, Dr. Basu. Yes. Any questions?
I think you should also keep porphyria in mind. You may not be
Yes.
practiced in the
Yes,
cases in
yes,
India.
yes.
But if you,
This erythropoietic.
so you go to South Africa, then you will land up with hereditary porphyria. If you're looking at Punjab, then you'll get a number of cases of acute intermittent porphyria. The presentation is very similar. Altered sensorium, weakness in the legs, and abdominal cramps. So that's one issue. Another interesting case I can talk of lead poisoning was I had a policeman who actually had gunshot wounds in the leg. They couldn't remove all the pellets. So
Ah,
down the lane, he became anemic, and it was the pellets in the leg,
Yeah.
usually the pellets, and so he was absorbing lead from that, and with the patient having it. So in a lead poisoning, it can happen two ways: that it will present as an iron deficiency picture in the first case. You may get an iron deficiency like a peripheral hemogram, but the basophilic stippling is the clue that the underlying lead poisoning may be a cause of this microcytic hypochromic, so not necessarily a normal hemochromic. So these two conditions you have to keep in mind. Altered sensorium, if you have with basophilic stippling, think of a porphyria also as an alternative diagnosis according to your geographical presence.
Thank you so much, Doctor. So nice. Very good comments, and thank you so much. So can we proceed to the case 4? This is a 6-year-old. Sorry.
Yes, ma'am. No
Yeah,
questions so far.
this is a case. This is a 6-year-old child who had fever, body ache, pallor, and can somebody describe the findings to me?
Hemoglobin is 9.8 gram%, which is
Yes.
less than normal. TSC,
Yes.
which is 19,900, which is quite high, and platelet that is 38,000, which is very less.
Yes.
The normal of 1,50,000.
That's the blood picture. Can you comment on the blood picture of this case, please?
From this side, I can see fragmented RBCs as well as mild anisocytosis. I can see the orangish hue of the WBC neutrophils, so it can be toxic granules as well. And acanthocytes I can also see.
Right. You're absolutely right. So the high count that is there is due to neutrophil leukocytosis. Neutrophils are not the predominant cell in a child. And anisopoikilocytosis, the poikilocytes are there. A lot of fragmented. These are the fragmented cells. And you have schistocytes. Schistocytes with acanthocytes, very rightly said. Now the schistocytes, if we have said what are the differential diagnosis and what further tests will we do? We are looking at a case of microangiopathic hemolysis in which you see these schistocytes. These are the schistocytes. This is with sepsis. You can see inflammation, acute neutrophilic leukocytosis, thrombocytopenia, schistocytes, and toxic granulation. In this case, you don't see any cells, but you see schistocytes, hypochromia, acanthocytosis, and thrombocytopenia. We know microangiopathic hemolytic anemias can be due to DIC, hemolytic uremic syndrome, and PPP. All these three are part of microangiopathic hemolysis, and the clinical picture will decide which way and who is under which category. Blood picture is only showing you microangiopathic hemolysis. Normally, DIC can be seen in any age group, right from newborns to an 80-year-old patient. Hemolytic uremic syndrome is usually seen in children. Acute injury, infective, like in this child, and has renal shutdown, and they present with uremic syndrome, that is hemolytic uremic syndrome. Then, what we call HUS, PTP is usually seen in elderly people who have more of CNS symptoms and have microangiopathic hemolysis. There are different causes for these, and one has to find out according to the age and the clinical correlation. Schistocytes, when we are seeing, are seen. This is basically a Greek word. Schist means divided or a split cell. It is eros, that is schistocyte, hollow cell. It's a fragmented part of a red cell. Typically irregularly shaped. It can have two pointed ends or maybe having one pointed end. But what is important is true schistocyte does not have a central pallor. So that you will have a lot of fragmented cells, but a schistocyte you will only call when you don't see a central pallor. They're also called as helmet cells, and you can take different shapes. It may be triangular, helmet-shaped, comma-shaped, may have pointed edges. Here, it is looking like little fragments, fully hemoglobinized, no central pallor. Here also, you can see these schistocytes, fragmentation. These are all fragments of RBC which are in this shape, and that is the definition of schistocytes, which are the hallmark for microangiopathic hemolysis. So, if you are thinking of these conditions, you will ask for certain tests, and basically you're looking at thrombocytopenia and certain coagulation tests like prothrombin prime, APT, B primer, renal function tests. Yes, please. Any comments? Any questions?
Ma'am?
Yes.
By seeing the peripheral smear, I was confused with RBC as echinocytes. Ma'am, how to differentiate between echinocytes and acanthocytes?
Acanthocytes are round cells with all ragged borders. Acanthocytes have irregular membrane all around it. Little spinous, but they're not like pycnocytes, which are small like spherocytes. They're dense. Pycnocytes are dense cells. Acanthocytes still have central pallor. Now, these are the ones which are shaped into different fragments, and they're fully hemoglobinized. Echinocytes can have central pallor. That is how you will differentiate these from true schistocytes.
Ma'am, Varishta Shaw has asked, can we
Yeah.
distinguish microangiopathic and macroangiopathic on PBS?
Basically, microangiopathic is typical. If there's nothing like a macroangiopathic, if you call it, basically that's hemolysis. And whatever angiopathic hemolysis can be micro or macro is damage to the red cells. And that is what is called the angiopathic hemolysis. Usually it is called as microangiopathic hemolysis because the cells are broken and they are into smaller fragments. Usually you do not see macrocytosis in these cases, which may be due to certain other reasons, the macrocytosis. But you will not see the schistocytes in those cases.
Ma'am, there is one more question from Sadia Begum.
Yes.
How to say anisocytosis is mild?
Very difficult to say. If you can't categorize it or calculate it or put a number to, it's basically arbitrary and your own judgment. When you see that all the cells in one field are little over each other, that means very little variation in the size, you will call it mild anisocytosis. However, RDW is the one which helps you. If there is too much of anisocytosis, you will have variation, marked variation in the cell size. And that gives rise to, but whether to call it marked, you can call it marked like this case I showed you of megaloblastic anemia. You see a lot of variation in the size from micro to macro to normal. Whereas mild anisocytosis is little variation in the size and you can't put a figure on it or a number on it.
Okay, thank you, ma'am. Okay, any comments from our...
Yeah, Dr. Basu, Dr. Rajan?
No, nothing such. Excepting in the investigations, all of you should be aware of something called a DIC score.
Yeah.
In all cases of suspected DIC, please follow the score, which includes PT and D-dimer and platelet count also included in that. That's
Yes.
good. Also, currently, in some places, we are able to demonstrate the ADAMS2 deficiency for TTP.
Understood.
So that also comes as a part of your investigative protocol. If you have the facilities, you can do that. That helps you out in the TTP part of it.
Yeah, we are
And
doing
the question from Varishta about macro angiopathic, usually we don't use the term, but I presume you mean with those angiopathic and thrombotic angiopathy that takes place in, let's say, due to some defect in the valves, prosthetic valves, or in bigger vessels. That is generally we don't use the term. That also
We
shows
don't
the
use that.
but usually we don't get so much of thrombocytopenia in those situations.
Yeah.
So that's more of a clinical kind of a differential. In some cases where you have a bad valve, cardiac valve, which is prosthetic or infected, you might get RBC slicing and show, or things like what was earlier known as March hemoglobinuria.
Yeah.
Long marching. Those situations, marathon runners do have it, but there it is a kind of a transient hemolysis and not so much associated with thrombocytopenia as such.
That's right. These are all causes
More
of
of a clinical.
microangiopathic hemolysis, basically. Classic. Thank you, Dr.
And
Basu.
this is
Thank you
something. This is a kind of a emergency situation. All these conditions, especially TTP and HUS. So all of you must be able to identify schistocytes correctly. Storage artifacts should not be missed for fragmentation or crenation, and also keep that in mind. If schistocyte is the main morphology with polychromatic cells and thrombocytopenia, you're dealing with a microangiopathic morphology.
Yeah.
So be prepared. You should be able to identify the situation. It's actually a very critical clinical condition that needs to be identified.
Yeah, in fact, there's a question how to differentiate crenulated RBCs due to preservation artifact from echinocytes.
From true crenations. Okay, true
Yes.
crenations. Yeah, would any of you like to answer this? How do you say it's a storage artifact and not true crenation, or vice versa? Anyone wanting to venture out? In storage, you will find uniformly all the RBCs.
all the RBCs.
Okay, and you will see other changes in the WBCs, Madam Short pyknotic changes, or platelets being giant platelets. Whereas in actual true crenation, obviously all the RBCs won't be crenated, right? So you'll have a few normal RBCs interspersed with either crenation or echinocyte-like cell crenations. Okay, so that is how you generally differentiate.
Dr. Mugdha has asked if schistocytes are less than 1%, how to report?
Yeah, even if a single schistocyte is seen, it is a schistocyte. So you have to count the schistocytes, and the number does matter. So you have to, I'm not going into the detail of the microangiopathic hemolysis, but you have to see even a single schistocyte in an oil immersion field should raise an antenna that this patient is having some element of microangiopathic hemolysis, whatever may be the clinical condition. So you have to see a true schistocyte and then be sure and bring it to the notice of the clinician. Coupled with that, if you have thrombocytopenia and if you have evidence of sepsis or pancytopenia, then the seriousness of the case increases, it increases. So we do count schistocytes. We get sometimes percentage if you can, but it does. Even few schistocytes are important. You can't afford to miss it. Like Dr. Basu said, it is an emergency situation and you can't sit over it. You have to tell the clinician that this patient is, depending on whatever is the clinical picture, it is microangiopathic hemolysis, which you see on the smear.
There is one more question regarding this case. Is polychromasia and normoblast needed in diagnosis of microangiopathic hemolytic anemia?
No, they're not needed because please remember, usually in patients of HUS and severe infections, there is a marrow depression. Polychromasia may not be a feature of this and you will still see schistocytes. Many cases of secondaries in the marrow can also show you depressed reticulocytosis, but microangiopathic hemolysis. So polychromasia or NRBCs don't have to be there to call it microangiopathic hemolysis.
One question, ma'am.
Yeah.
Ma'am, besides the schistocytes, can we differentiate between TTP and DIC if other investigations are not given?
No, both have the same picture. You cannot differentiate between DIC and HUS. TTP doesn't have that much of thrombocytopenia, and it's usually in the elderly person. But yes, blood picture is the same. So what is important is DIC is an acute emergency. It has the same picture, and HUS is also an emergency, and both have the same picture. Both can show you evidence of sepsis, both can show you toxic changes in the granulocytes, or depending on whatever is the reason, there are a whole list of causes of DIC. HUS is usually in children with acute infections, and TTP usually in elderly. But the blood picture does not differentiate between HUS and DIC, unless you know. But if you see a picture like that, you should ask for the renal parameters. You should ask for urea creatinine and PT-APTTs.
Thank you.
Yeah.
PR has asked a formation of fragmented RBCs during dialysis reflecting in peripheral blood smear. Is it common?
Yes, you can see it. You can see fragmentation during dialysis. We see this kind of fragmentation. You'll be surprised in neonates who are put under phototherapy. Their smears can also show red cell fragmentation, but schistocytes are very few. Schistocytes are very different from fragmentation. You can have some fragmentation in all cases of patients who are going through dialysis. You can have fragmentation. Yes.
Thank you, ma'am.
Okay. So this is a case. 1-day-old neonate. I have not given these now. I'm running through the peripheral smear for different conditions. So we are going to discuss a neonate now. It's a 1-day-old with 11 grams, 28,900 WBC, 89,000 platelets with a retic of 8%. Can somebody describe whether for a 1-day-old neonate, what are the parameters which are out? I have anyway highlighted them, but how and why? Can somebody answer that? Okay. A neonate, day 1 neonate is usually having hemoglobin above 13.5 grams to 19 grams. So So this patient is definitely anemic. 1 day old at 11 grams. WBC count can be anywhere from 15,000 to 35,000 in a neonate. So the WBC count is within normal range. Platelet count is usually like the adult levels. It is 150 to 450,000. However, this child has 89,000. So he is mildly thrombocytopenic as well. Retic count is the one, or polychromasia when you're describing a smear from a neonate is very important because that decides whether the baby is hemolyzing or not. Normally, your neonatal consultants will ask you only few questions. Is my baby hemolyzing? Is my baby septic? And why is my baby bleeding? These are the 3 questions which normally the neonatologist will ask you. And how do you decide about the hemolysis in a case? A day 1 year old, 1 day old neonate, 8% retic is little high, up to 5, we take it as normal in a neonate. This retic falls to almost 0 by day 7. So there should be no polychromasia in the peripheral smear of a baby who is 7 to 9 day old. If you see polychromasia, that baby is definitely having some element of hemolysis or having bleeding somewhere. That was the blood picture of this baby. You can see macrocytosis, and what else do you see here? Sorry? Spherocytes. Yeah? These are macro. Most of the babies have macrocytosis, which is normal. The MCV is normal in neonates till about 3 weeks, 2 to 3 weeks. So that was the picture. This is without any, not much polychromasia, but you see the spherocytes. Here the spherocytes are there with a lot of polychromasia, NRBCs. This is a typical case of spherocytic hemolytic anemia of the newborn. Very characteristic. What can be the cause? Can somebody come out with some suggestions? A spherocytic hemolytic anemia in a newborn having spherocytes. Okay.
Band 3 mutation.
Sorry?
Band 3 mutation.
Normally, spherocytic hemolytic anemias in the newborns are due to immune-mediated hemolysis of ABO incompatibility. The moment you see spherocytic hemolytic anemia, ask for the blood group of mother and ask for the blood group of the baby. Usually, the mother is B or A and the baby is O. That is what is happening in these cases. So you have spherocytic hemolytic anemia in these cases. It has, in contrast, a rich hemolytic disease of the newborn, which you can see here. You have polychromasia, you have NRBCs, but spherocytes are only rare. You don't see spherocytosis or presence of spherocytes is rare. They are there, but they're not the predominant cell in a Rh incompatibility. And that's how when you see a peripheral smear from a neonate, you have to see this and tell the pediatrician or the neonatologist that this baby is ABO incompatibility, likely to be that, or hereditary spherocytosis. Both it can be. Now, and this is usually typical of Rh hemolytic disease of the newborn. Other causes of spherocytosis, we know, besides hemolytic disease of the newborn, autoimmune hemolytic anemia, hereditary spherocytosis, enzymopathies unstable, HBE, burns, and paroxysmal cold hemoglobinuria. These are all. So if you see spherocytosis on the peripheral smear, you have to think of all these conditions and think of who is your patient that you can. Now, what will you do further? Direct antiglobulin test, osmotic fragility. I'm not very fond of osmotic fragility because it depends on the number of spherocytes that are present. Some cases, by the time they come to us, I've already ruptured the spherocytes. There are only polychromasia. You may miss or you can have a normal osmotic fragility. Look for hemoglobinuria and hemosideриnuria, which is pointing towards an autoimmune hemolytic anemia. This was a classical case of a 4-year-old child who had splenomegaly, jaundice, moderate, and this splenomegaly we were thinking of, is this a storage disorder or hemoglobinopathy? Hemoglobin was low, 4,500 WBC with a red high, bilirubin high, mainly indirect type, and the electrophoresis was normal. That was the blood picture of this child. Bone marrow was done. Bone marrow did not show us any storage disorder. TLC, as I said, was normal. Why I want to share this case with you is that this was a case turned out to be of hereditary spherocytosis. Where to look for the spherocytes is very, very important because hereditary spherocytosis is the most missed diagnosis. Osmotic fragility, as I said, will depend on number of spherocytes. So in this case, you must look, or any case when you are suspecting that you have indirect hyperbil, splenomegaly, and maybe spherocytes, look for spherocytes in an area of the smear where there is little overlapping of the RBCs, and any RBC which is lying single, normally they should show you a central pallor, but if any one of them does not show you a central pallor, that is a spherocyte. It's very important to note this point because if you go towards the tail end, all will become spherocytes. That's an artifact. So you please have to know where to look for the spherocytes. And in this case, it is there in an area where little overlapping of the RBCs, any single cell line should show you pallor. Look at these 3. But any one which is not showing you little smaller, little denser is a spherocyte on a peripheral smear. Hemolytic anemias, when you look at the smear, you will always see an isopoikido. You will think of all the cases of hemolytic anemia, and you will confirm with the oh, why is this come up? Okay, with the HPLC, which will show you that it is fetal hemoglobin, which is high. So this was the case of thalassemia major. Sickle cells may not oblige you by coming and showing themselves in all the smears. You have to be very careful that schistocytes, the sickle cells may be seen like this one. It is called a tactoid cell. It's a rectangular cell. And pure sickle cells are sometimes rare to see in the peripheral smear. What happens in India? We have patients who have associated either alpha-thal deficiency or Arab haplotype, in which case the fetal hemoglobin is very high along with sickle hemoglobin. And that fetal hemoglobin protects the patient for sickling. And in the smear, you may not see many sickle cells, but you may see these tactoids, which are rectangular cells. So in a peripheral smear, please pay attention to these fully hemoglobinized rectangular cells. And when you're thinking of hemoglobinopathy in the peripheral smear, you will do all these tests to confirm the diagnosis. Coming to the next, what do you see here in the peripheral smear? Somebody quickly. Okay.
Target cells.
Target cells, yes.
How will
You
they
can
look?
see target cells, you can see acanthocytes. Somebody mentioned acanthocytes. Here are acanthocytes all over, but with a central pallor. And what do you see here?
Well,
Howell Jolly bodies. So when you see peripheral smear Howell Jolly bodies, please think of all these conditions, and you must see who is your case. Either it is congenital absence or after splenectomy. It's very important for you to recognize that patients of ITP who have been splenectomized, the clinician is interested to know whether the accessory spleen has come up or not. In which case, it's your duty to look for Howell Jolly body. If the Howell Jolly body is present, that means spleen is not there. So you have to tell him that don't worry, there is no accessory spleen. The patient is totally splenectomized. And in ITP patients, you need to tell that to the clinicians. Besides that, there are many other causes of splenic atrophy occurs in sicklers, sickle cell homozygous patients. After the age, they start having a small atrophic spleen and they start showing Howell Jolly bodies in the peripheral smear. Of course, these are other causes of hyposplenism, and celiac disease is also one of them. Elliptocytosis, when you see on the smear, you must see that if elliptocytosis hereditary, you must see at least 25% elliptocytes. Then only you can call it or think of hereditary elliptocytosis. Otherwise, they can be seen in hemoglobinopathies, megaloblastic, myelofibrosis, and MDS, and even in iron deficiency anemias. So depending on who is your, how many are the elliptocytes, it will matter in that. Even in CDA, you can see these elliptocytosis. Sideroblastic anemia is another cause. So not 25% and more, don't think of a hereditary elliptocytosis, which can be seen as a hemolytic anemia and can be missed if you're not very aware of the number of elliptocytes to be seen. In hereditary elliptocytosis, all the cells are never elliptocytes, but they are more than 25% in the peripheral blood. Coming to another cell in the peripheral blood, which is stomatocyte, which has stoma, which is mouth-like opening in the center, and they can be seen in many conditions. Of course, hereditary stomatocytosis is there. Again, you must see more than 25% cells of having stoma. Otherwise, electrolyte imbalance in diabetic patients can show a lot of these stomatocytes. Alcoholism, liver gallbladder disease, cancers, and heart disease. So if you see stomatocytes, I normally see if it's an adult and I see few stomatocytes, I ask for serum electrolytes and ask for liver function. Rule formation in peripheral smear, we know, is telling us the reversal of the albumin globulin ratio can be seen in liver disease, inflammatory conditions, and can be seen in myeloma or all the plasma cell dyscrasias. Surprisingly, pregnancy also shows you elliptocytosis, these Rule formation. Agglutination on a peripheral smear is a very characteristic finding and shows the presence of cold agglutinins in an autoimmune hemolytic anemia. Can be due to mycoplasma, infectious mononucleosis, or any lymphoproliferative disorder. Look for these autoagglutinations, usually best seen under low or maybe little higher power. 40x, you should be able to see these agglutinates very beautifully. They may even show you erythrophagocytosis in the peripheral smear, seen many times in paroxysmal cold hemoglobinuria or even sometimes in autoimmune hemolytic anemias. These cold agglutinations or autoagglutinations are usually, as I said, are seen in cold agglutinin disease. Coming to the leukocytes in the peripheral smears, neonates, very important. Sepsis, as I said, is the burning question. This is what we have been following. Neutrophil band cell ratio, more than 0.0 with eosinopenia. I lay a lot of importance in the peripheral smear to the eosinophils. As I go along, you will see, especially in pediatric age group, eosinophils may or decide what is the problem in that child. So eosinopenia with neutrophil band cell ratio, especially in a case who is day 1 to day 5 old. Please remember this formula of more than 0.2 is more working in the patients or neonates of day 1 to day 5. We know that neonatal smears of packed RBCs, they have a very high PCV. Sometimes to get an area which is very good, where you can see the lobes clearly, may be difficult. These band cells are normally seen in day 1 to 5. And TLC may be normal or high or low, but band cell neutrophil ratio is usually less than 0.2. If it is more than 0.2 with eosinopenia, you will see that the patient of this child is definitely septic. Sick granules may be seen but are not mandatory. We see them in patients, babies who have been kept under phototherapy. Dole bodies, vacuoles may also be made because of that. So you can't say that it is due to sepsis. But these two top things are the ones I take it as areas of sepsis. In this day 1, day 5, you divide your band cells to neutrophil and you get a ratio of 0.25, but eosinophils are 0. I will call this baby septic. More than day 5, band cells should not be seen ideally. But if from day 1 to day 5, they have spilled over to day 6 or 7, but again, you should have eosinophils. And if eosinophils are seen with band cells, I don't worry about this. I think eosinophils are very friendly and they give us a lot of confidence that this patient is not that sick, provided there is, if you see this cell, this is a circulating histiocyte. This is a very bad sign in a neonate. This child will never make it because these are severely septic babies. If you see circulating histiocytes with eosinophils, very bad sign, because that shows that the adrenals have packed off in that baby also. Very bad sign. So please look at the neonatal smears very carefully. Neutrophil leukocytosis, we know, can be seen in many conditions in the peripheral smear. Again, I give a lot of importance to eosinophils. I'll go a little fast to get a lot of time. Approach to a patient of neutrophil leukocytosis will depend on a number of factors with little bit of clinical correlation. I would ask for ASO10 in a patient like this who has fever, rash, and joint pain. WBC neutrophils are not the predominant cell in a child. Toxic granules, when they are seen, can be seen in neutrophil leukocytosis. If they are with eosinopenia, that is severe bacterial infection and can be acute abscess or necrosis also. Most of the patients of malignancies who have 50,000, 80,000 WBC count with neutrophils, they usually harbor somewhere an area of necrosis in the body, which may be a very necrotic malignant tissue. Eosinophils and abscess can be the liver abscess, can also show you the same. Of course, chronic myeloid leukemia will show you leukocytosis with basophilia. Hewitt anomaly, we know, can be seen in a number of conditions. But if it is hereditary, we have a family. Whenever I need a sample, I call them. I said, come and give me a smear. They are all, it's a hereditary Hewitt in that family. Otherwise, MDS, Fanconi's, and any of these conditions can cause a few Hewitt cells. They are bilobe things that we call spectacle-looking cells. The lymphocytosis is seen when you have the WBC count. In the normal range is 1.5 to 3.5, that means 1,500 to 3,500. And absolute lymphocytosis defined when you have cells, lymphocytes more than 5,000. Causes can be many, it is already given in many books. If you see atypical lymphocytes with a little pale area next to the nucleus, perinuclear halo, and blue cytoplasm, depends on who is your patient. And depending on that, you will have the conditions you will investigate a particular case for. Thus, you will think of any virus, EB virus, lymphomas, and of course, dengue fever can give rise to these cells. This 19-year-old boy had skin rash, cervical lymphadenopathy, and mildly reduced platelets at 11,000. Very typical case of a young person, probably he asked for STP, albinal, and CMV, IgM, or EB virus nuclear capsid antigen for infectious mononucleosis. The lymphocytes, depending on the morphology, can be depending hairy cells, CLL hairy cell, or other pro-lymphocytic leukemias can be seen in peripheral smear. Hairy cells may not show you such beautiful hairy processes, but they are seen in the peripheral smear. And you have to look for them because they will be seen as pancytopenia, and it is something which you people have to investigate carefully. The cases of leukemia in the peripheral smear can be acute lymphoblastic. 7-year-old child, interestingly, showed eosinophils with platelets borderline, normal WBC, and mild anemia. The important thing is, I trust lymphopenia. And this is usually reported. Many people with 5,000 WBC will report it as neutrophil leukocytosis. No, it is lymphopenia which is happening. And all viral exanthemas can have this kind of a lymphopenia. The causes of lymphopenia are many. You can have a look and investigate the case according to your case that is showing you. Now, coming to the COVID, we did a lot of this COVID lymphopenia, and we had a lot of correlation to the severity of the patient. If the lymphocyte main count was, or lymphopenia was more than 20 or less than 20, but I don't know how much it really helped. But lymphopenia was seen very classically in COVID cases as well. Monocytosis, we know, can be seen in peripheral smear, and we due to a number of reasons. And eosinophilia is very important. I put a lot of weight. Look at this child, has 35,000 WBC, mild anemia, mild thrombocytopenia, and a lot of neutrophils, eosinophils in the peripheral smear, all very mature looking. Thrombocytopenia. So I was thinking, what's wrong with this? Put him on hetrazan. Probably has some kind of eosinophilia, like Loeffler's, or maybe some allergic condition, or worm infestation. He had 76% eosinophils. Did not show any parasite. Given hetrazan. Why I'm sharing this case with you people is to treat eosinophilia with respect in children, in pediatric age group. The pediatrician insisted please do a bone marrow because he had mild splenomegaly. I said, why do you want to do a marrow in a child who has mature eosinophils? But my horror, child turned out to be acute lymphoblastic leukemia. And in the marrow, what do you see? Only blasts. I hope you can appreciate here. And eosinophils, mature eosinophils, blasts and eosinophils. Please treat eosinophilia with respect in childhood. There's another case I'm sharing, 75% eosinophils. This child had SGPT high, WBC count very high, 72,000, with mainly eosinophils, loss of appetite, fever, and SGPT high. Bone marrow we did again, nothing, just mild myeloid hyperplasia with increase in eosinophils. Child had hepatomegaly, so we asked for a liver biopsy. And what do we see? Granulomas and the larvae of Capillaria hepatica. What this child was doing was, I asked the mother, I said, where did he get this worm from, the larvae? That they have a house in the village where they have a ground floor house, and the child was picking up the rat droppings, thinking they were sweets, goli, and he was eating those. And that is where he got Capillaria hepatica. Please be aware that eosinophils in children have to be treated with respect. Another one, child 11-year-old came with huge blue blood patches, spontaneous intermittently, leukocyte count high, platelets normal, then eosinophilia, and hetrazan, but no response. Complete coagulogram. That's how we report our coagulogram. And only the bleeding time was prolonged. All the other coagulation parameters were normal. So when you have a normal platelet count with an increased bleeding time, you will think of a platelet function defect. So we asked for a platelet function test. And in this case, we had grigometry, showed no aggregation with collagen, reduced with ADP, and normal with vistocytine. This surprised me. I was not aware of this condition. There was a consultant who had come from Vellore, And he said, Madam, this case is acquired platelet function defect with eosinophilia, the APET case. And this happens to be a very peculiar condition to the Indian and the eastern part of the world, that you have this condition, that you have eosinophilia. Usually worm infestations are there, and it's a very clinically interesting condition where there is platelet function defect, which can vary. We got a collagen defect, others may get an ADP functional defect, treated with anti-helminthic treatment, and the case never came back to us. Please treat eosinophilia with respect in children. Leukoerythroblastic blood picture, we are all aware of. You have erythroid cells, you have myeloid cell shift, and you can think of a whole lot of conditions which can cause leukoerythroblastic blood picture. This was a patient kind of osteopetrosis with a leukoerythroblastic blood picture and a tear-dropping cell. So you can think of all these conditions like storage, Niemann-Pick. You can have cryptococcus, histoplasma, LD bodies, all these infiltrating the marrow can cause leukoerythroblastic blood picture. If you see a megakaryocytic fragment in the peripheral smear, that is a very sinister sign and can be myelofibrosis with myelodysplasia. Do not ignore to report this finding. You can see the tear dropping also. Coming to the platelets in the peripheral smear, we know that these automated instruments can view false pseudothrombocytopenia, can be due to EDTA induced. We are seeing these more and more these days. And before releasing any platelet count, please look at your smear. Don't report a low platelet count without your smear, because it may be a giant platelet, which the counter will not count, or it may be platelet aggregates, which again the machine will not count, although they're very adequate, and there may be platelet satellitism. So please, thrombocytopenia should be confirmed. Look at the tail end of your smears for EDTA-induced aggregates. It's very important because thrombocytopenia otherwise can lead to different types of tests being done in these patients. Automated instruments can create. The platelet counts, you have to be very, very careful. High counts can also be there if you see leukemia, the fragments, bacterial fungi, and severe microcytosis. Always confirm with the help of a peripheral smear. And cytopenia in the peripheral smear, we know can be due to many conditions, aplastic anemia, or can be due to hypersplenism, like in this girl. In which case, peripheral smear will show you normal differential if it is due to chronic liver disease and hypersplenism. Compared to aplastic anemia child, it shows you a normal differential with neutropenia. So that peripheral smear helps you in differentiating the cause of pancytopenia in these cases. Cause pancytopenia, you must think of hemophagocytosis and of course leukoerythroblastic. Few cases I want to share with you that a peripheral smear can give you molecular diagnosis. It's really important to pay attention to your smears. We know that drumstick can tell us it is from a female that you are looking at. This is a smear from a female drumstick, but molecular defects are picked by peripheral smear or rods like nuclei, which are very typically seen in certain cases of acute myeloid leukemia, are usually molecularly NPM1 or FLT3 ITD mutations. So a smear can tell you molecular defect you are looking at. This child was very interesting because look at the acanthocytes and the pycnocytes on the peripheral smear. He showed neutrophil leukocytosis, 25% retic, so there was element of hemolysis that was going on. Pycnocytes, leukocytes, we had no history of this child. So what did we do? We repeated that smear shows evidence of hemolysis. Look at these pycnocytes and acanthocytes all over the smear. We said, okay, do a DCT, do beta lipoproteins, rule out red cell enzymopathy, PK deficiency, G6PD, and to please inform clinical details. To our surprise, the child came to the laboratory. It's a child with bow leg, was probably diagnosed as renal rickets, but turned out to be, he did not have normal milestones, bowing of legs, full-term normal delivery, but had acidosis. And this was a typical case of renal tubular acidosis with hemolytic anemia, and this is with a very characteristic molecular defect for red cell membrane in the band 3. You do the eosin 5 melamide test, which we got done from IIH Mumbai, and they confirmed the diagnosis. It was the AE1 mutation. So you can be careful if you're looking at these cases of acanthocytosis in a child. Please look carefully. Fresh smear was the one which helped us. You can pick up this Jordan's anomaly. This is evacuation in a fresh smear. In an anticoagulated smear, I sometimes disregard the evacuation of the neutrophils. But if you see in a fresh smear, this was an 8-year-old child, had skin rash, scales. This history comes to us later. We report as anemia, microhypo, and with evacuation, Jordan's anomaly. And then comes the history. 8-year-old, congenital ichthyosis, acromegaly, strabismus, gliovalgum. This was the case. Look at dry skin, gliovalgum. Look at the ichthyosis, the squint. This was a case of Hoffmann-Kanarian syndrome. You can pick it up on a peripheral smear of these cases. Under lymphocytes, you can pick up mucopolysaccharitosis. This was a case who had gray hair, silver gray hair, splenomegaly, atypical lymphocyte with lymphocytes in the peripheral smear. This case turned out to be another case of mucopolysaccharitosis. He had albinism, Griscelli syndrome with his hair, and subjected it. Actually, now we don't even stain it. We just see it under the microscope. If we think of any of these Griscelli syndrome, you can just see this is a normal hair, and this is the hair of the golden brown pigment which is there in these children. Lymphocyte accumulations are seen in many cases of mucopolysaccharitosis. They are punched out vacuoles. You must not ignore. Please look for them carefully. And this child had 2 years old kyphosis, and this turned out to be a case of gangliocytosis DM1. Shadia Higashi, you can pick up on the peripheral smear with that inclusions in the lymphocytes, and in the marrow you can see these giant Shadia Higashi inclusions. All these can be suspected from a peripheral smear. This was an 11-year-old child, splenomegaly, and again had 82% lymphocytes. If you look carefully, this child had huge lymph nodes cervical and hyperpigmented and hypopigmented areas of the skin. He was the one who showed these large inclusions and had inclusions in the marrow as well. This patient was Sheilia Higashi with huge lymph nodes in the cervical region, which we classically reported later as Hodgkin's because they are immunodeficient. He had lost a sibling also earlier. From a peripheral smear, if you see Dole bodies, these blue bodies on the in the cytoplasm near the periphery, and you can have certain molecular defects, like in this child, it is May Hagelin anomaly. You have giant platelets and Dole bodies. You can have these in many cases, and you can suspect MYH9 disorders in which you have giant platelets, thrombocytopenia, Dole body-like inclusions in the granulocytes. These are all seen in the peripheral smear. These are all the disorders which fall into May, Hagelin, Sebastian Fetcher, and Epstein. They are all MYH9 disorders, can be picked up from a peripheral smear. Of course, you can pick up the malarial parasite. Sometimes you don't find the parasite, but you see the remnants of the hemozoin pigment in a monocyte histiocyte cell. You can see types of parasite can be filaria, trypanosome, and of course these. This was an interesting case. This was a 62-year-old man who was admitted and was having stroke, blue discoloration of the left fingers of his hand. He was admitted in the ICU with stroke. Neurologist was consulted for his stroke, hematologist because he had thrombocytosis and he had probably a myeloproliferative disorder, which was not confirmed. The lab score was normal, marrow was normal cellular, mild hyperplasia, was leukocytosis, nothing came. Clinically vasculated because of the blue fingers, hematologically chronic myeloproliferative disorder, and neurologically it was a stroke. Was put on hydria because his platelets were more than 13 to 16 lakhs at all the time. He responded to hydria, came for a repeat test. That day the platelets were 10 lakhs. Leukocytosis was there, and what we saw was one cell like this, which was shocking to me, with Howell Jolly body. Can you appreciate this Howell Jolly body here?
Yes.
Here, and this cell, I said, oh my, this looks like a sickle cell because it's a fully hemoglobinized cell. He's in a peripheral smear. You see double the width of a normal RBC, fully hemoglobinized. It is a sickle cell. And this case was sickle positive, 62% sickle and 38% this. Had no organomegaly, no spleen because of autosplenectomy. Why I'm sharing this, that it was the peripheral smear that where we picked up this diagnosis. I would never think of sickle homozygous in a patient of 68-year-old man. He had no previous episode, totally protected throughout his life, never had any morbidity. And this was sickle cell syndrome, the genetic workup. He had alpha gene deletion. So this was essential thrombocythemia, post-autosplenectomy, leukocytosis, and myeloproliferation. Friends, cases of familial hypertriglyceridemia. Please look at the smear. It was a beautiful smear. In between were all chylomicrons and lipids in between the cells. First, I thought it was an artifact. I said, no, call the patient again. Let's make another fresh smear. We could not even stain the cells properly. The lipids were so many. And this was 32-year-old female with familial hypertriglyceridemia. So please look at the CBC data as an organ, correlate very well, all the parameters. Look at the interpretation, look at the morphology, RBCs, look at the morphology, correlate everything, and of course, the parasites, not to forget. All this from a peripheral smear. You can imagine how much wealth of information is there. It is like a Sherlock Holmes. You have to put the pieces together and then come to the diagnosis. Look at them carefully, observe, analyze, please correlate, and then interpret the case. Thank you so much. Any questions are most welcome. Any comments also from the two experts who are here? I know it has taken a long time, I think. And thanks for being there all this time. No questions?
There are some questions.
Any questions in the chat, please?
There are questions.
Let's take those. Yeah.
Can spherocyte be seen in normally after transfusion?
Yes, they're seen. They are spherocytes. They are seen after transfusion. But where will you see them? Again, in an area where to say that they are spherocytes. See in an area where they are little overlapping of RBCs. Any cell which is lying single without a pallor is a spherocyte. They can be seen post transfusion. They're there usually.
One more question regarding spherocyte. How many spherocytes are required to suspect spherocytosis?
Oh, no. There is no quantification. As I said, I've seen patients of hereditary spherocytosis coming to us after an acute hemolytic episode. So you have only polychromasia, normocytic normochromic cells, and only occasional spherocyte which is left, which has not ruptured. So you can't go by the number. If you're very sure in a peripheral smear, fresh smear, few spherocytes are also significant. Please report them.
Ma'am, PR has asked when will Howell Jolly body start to appear after splenectomy?
Yes, immediately. Yeah, within 24 to 48 hours, you will see them. They're there. The moment you clamp the splenic artery, they start appearing because the pitting function of the spleen is disabled. And all those fragments start coming into the circulation. You will see them.
Then what are the causes of force versus fine basophilic stippling?
As I said, forced basophilic stippling can be seen in drug-induced stippling, usually lead or many other drugs these days. But fine stippling is usually seen in thalassemias, usually. But of course, as I said, there is a whole list of disorders which will show you stippling.
Then how to differentiate elliptocytes and pencil cells?
Yes, the elliptocytes are almost like pencil cells, but they are rounded at the ends and they are proper elliptical shapes. And that is how you will differentiate them. You can call a few elliptocytes in a peripheral smear. We may call them pencil cells. Yes, Dr. Basu, any
Yeah, no,
comments?
the typical pencil cells of iron deficiency would be hypochromic.
Hypo, that's what it is.
Elliptocytes are not hypochromic.
Yes.
Ma'am, Chitravati has asked in sickle cell there is splenic atrophy. However, in some adults, moderate to severe splenomegaly is noted. How can it be explained?
Now, these patients are usually in Indian subcontinent. We see a lot of patients of sickle homozygous who are actually with, like this one I showed, they are either sickle thal or they have associated alpha thal, in which case there is splenomegaly. You will see splenomegaly in patients of Indian subcontinent. We see a lot of them. They have 60-70% sickle hemoglobin and rest fetal or very little A. So that is usually seen in our patients, which is never seen or rarely seen in Bantu population in African countries. You don't see that kind of, they have more leg ulcers. We do not see leg ulcers so classically in India.
The audience also wants to know, please explain neonatal sepsis day 1 to 5.
Neonatal sepsis day 1 to 5, do your band cell count. Do your 100 cell differential. In that 100 cells, please count all the WBCs. Divide your band cells with the neutrophils and you will get a ratio. If that ratio is more than 0.2 and you have eosinopenia, the patient is septic.
Then what is the reason of accidental finding of vitamin B12 more than 2000 with no other symptoms or previous abnormality?
This is these days of B12 more than 2000, no anemia, no problem. Some are anemic also. But they show high WBC count. 2-3 reasons. Either they are taking supplements in any form. These days, patients have a habit of popping pills or multivitamins or taking some special foods which are very rich in B12. But this high B12 does not bother because it is going down the urine. It is taken out. It does not harm us. But it can be due to non-utilization also. If there is transcobalamin deficiency and the B12 is just circulating free in the circulation, you will again have B12 high. But usually they have neurological symptoms. So high B12 normally doesn't bother us. These days we are seeing lots of it. Maybe we should measure the active form of B12 than the total B12, what we are measuring these days.
How to differentiate between megaloblastic anemia from vitamin B12 folate deficiency versus liver deficiency?
As I said, the liver deficiency does not show so much of anisopoikilocytosis. The RDW is just above the normal. Whereas megaloblastic anemia, the RDW is, that means anisopoikilocytosis is marked. And there the RDW is very, very high.
Rekha Bhandari has asked, following blood transfusion, after how much time an HPLC can be advised for diagnosis?
Normally we say wait for 1 month. Definitely wait for 1 month if you can. Because many cases you cannot wait for 2 weeks even. Major cases, you every time, within 3 weeks the children come for a transfusion. So it depends who is your case. But normally if you can wait as long as you can. That's the best for HPLC.
In which area of the peripheral smear should be screened for rouleau formation?
Rouleau formation, as I said, usually between the tail and the body. You should see, not the head, see it in the body and not in the tail end, but in the body, not the head. So that is the area where you should see the rouleau formation. Dr. Basu, any comments?
No, I think so. It's a very nice, exhaustive presentation. You covered almost all the lesions possible in the face.
It's a book of hematology.
Yeah, I know. It's very nice.
Book of hematology. You can diagnose anything from there. Thank you so much for being there.
Yeah, we have covered most of the questions. Thank you very much, ma'am. We have covered most of the questions now.
Thank you.
Anything that I have left?